Okay, thank you all so much for joining the C3I Consortium meeting this afternoon. We're delighted to be joined by Dr. Timothy Mullett, the immediate past chair of the American College of Surgeons Commission on Cancer, here to talk to us today about the exciting new standard, the new smoking cessation for patients with cancer standard that will be implemented in January of 2026. This is a key milestone in this space, and so we're delighted to hear more about it and have a discussion with this group. And I'm going to turn things over to Dr. Michael Fiore, who will be introducing Tim. Go ahead, Mike.
Thanks, Mara. And I am, and welcome everyone for joining us today. I'm just delighted to introduce Dr. Timothy Mullett, professor of surgery at the University of Kentucky and director of the Markey Cancer Center Research Network. For over 30 years, Dr. Mullett has served as a cardiothoracic surgeon at the University of Kentucky, and his emphasis on smoking cessation has been informed in part by his work treating patients who have cancer as a result of their smoking. At the same time that all of us, as part of C3I of Advanced Smoking Cessation in NCI designated cancer centers, Dr. Mullett has worked to do the same in community cancer clinics. As Mara mentioned, he's the immediate past president of the American College of Surgeons Commission on Cancer, and during his tenure in that role, he oversaw the groundbreaking programs called Just Ask and Beyond Ask, programs designed to bring smoking cessation to the 1,500 community cancer programs across America, where 70% of cancer patients receive their care. His impact in this area has been just remarkable, and it has been an honor to work side by side with him. At the end of your career, Tim, you're one of those lucky individuals who could look back on as one of your many achievements, having fundamentally changed healthcare in America for the better.
Wow, Mike. Well, thank you very much.
What?
Go
Wait, did
ahead.
I'm not sure what that is, but just to finish up, Tim, you're an incredibly kind and generous man who's quietly but effectively made things happen. And so often you give other people credit for those things. It's been a privilege to work with you, and we're honored to have you here today to give an overview of the new Commission on Cancer standard for smoking cessation. Dr. Mullett.
Well, Mike, thank you very much. And your words are too kind. It has been a privilege to work with so many of the people that are on this call and to learn so much from the people on this call. The collaboration with C3I was a required element for this achievement of being able to lead to a standard. You know, I've been familiar with the work of the Commission on Cancer, and I'll go over some of the impact of the COC in my talk, but this has been a sincere honor to be able to see how we might be able to influence cancer care in ways that go so much further. And again, I've learned a lot through this process and owe a lot of that to many of the people on this call. Dr. Graham Warren, Jamie Ostroff, and Jessica Burris, to name a few, Stephanie Land, others that I see on this call. Obviously, Dr. McCarthy and Mike, your work has been incredible for being able to keep us focused and oriented in the process of achieving our goal of making it an expectation that every cancer patient that goes through Commission on Cancer accredited programs will be evaluated for tobacco use, and if found to be at risk for tobacco use disorder, then achieve a referral to effective tobacco treatment. And this follows a model that the Commission on Cancer has set forth in many other areas. And you may not know this, but the COC has been responsible for some of the breaking transformations in cancer care, such as multidisciplinary tumor boards. The expectation for uh, physicians and providers that are fully credentialed in their state as a board certified individuals, the impact on nursing staff, the impact on support staff such as survivorship and navigation have been critical. So the emphasis on all of these areas is actually tightly linked to the role of the standards that we have. So with that, let's just spend a moment, and I have to provide disclosure here that, as you said, I'm leaning heavily on several others that are here, and in fact, many of the slides in this presentation have actually come from Dr. Warren. But I think they are so well put together, and I think that it allows me to be able to share this information in a way that makes so much sense. Obviously, he's been a leader in this area for many years as well, and we're fortunate to have Dr. Warren join us at the University of Kentucky last year, and so it's an exciting or this year, and it's exciting collaboration that's forming, and so he's already hit the ground running. We are going to talk a little bit about, and this is clearly preaching to the choir, but I think it's level setting, and we're going to go over the impact of tobacco use in cancer care, understanding the importance of tobacco treatment, but learn about some mechanisms that we are going to emphasize that. And I think to be able to help bring this into focus, everybody, when I've talked around the country, about the role of tobacco and cancer, everybody focuses on the center of this slide, talking about carcinogenesis and the expectation that tumors are caused by tobacco, and they are, and many disease sites that we take care of. But the disconnect that is present is seen on the right-hand side, where we have worse biologic outcomes. We have worse clinical outcomes in terms of recurrence rate, toxicity, and mortality. As a surgeon, it influences our ability to safely get patients through surgery. And then the value outcomes, the cost of cancer treatment that's accelerated, and the cost of all of the consequences of ongoing tobacco use. And Dr. Goddard from the NCI has been very helpful in sharing this model in the bottom of this slide, where we see a pipeline, if you will, of healthy patients with no evidence of disease progressing to um, disease-specific death. And in this, there's the opportunity for us to be able to intervene with patients regarding their, in this case, tobacco use with prevention strategies. And this could be applied to many other things, whether it's other carcinogens or sun exposure or others. But in this case, we can prevent patients from progressing to disease by shutting the valve off with prevention strategies. And this is where we can link this with so many other opportunities here. But if patients progress into preclinical disease, we still have an opportunity to screen these patients now. And certainly with regards to lung cancer, we can identify these patients early and shut that valve off and prevent them from moving on to clinical disease. And then finally, for those patients that are symptomatic or otherwise found to have evidence of invasive cancers, then treatment options may be able to prevent that patient from progression to disease-specific death. So clear options for us to be able to highlight the role of smoking at each one of these. And this presentation really is sort of focused on lung cancer. That's an area, as a thoracic surgeon, that's an area that I've spent so much time in, and it links very well with what we need to do in terms of tobacco treatment for risk reduction. But it also is imperative for us to understand that even patients that once they're diagnosed with this disease, um, smoking cessation, just as I was talking with a patient before I moved over to this presentation, um, uh, who has been found to have three previous cancers. And this time talking to her about tobacco cessation, she was actually interested. And so I think it's okay. We can just keep the conversation going. But what we see is in this model of where patients have tobacco use and its population data showing per capita consumption in the red line, and then the delay in the development of lung cancers in the blue line in men and the green line in women. It is critical to understand that there's a lag time here that we have to keep an eye on these patients for a long time after exposure to tobacco. And so the role of screening and opening up the eligibility for screening in many of these patients is really important. But what we don't often think about is the fact that prevention, screening and treatment can avert nearly 6 million cancer deaths. And so, this is a huge impact for us to understand. And most of this from prevention and screening, and 98% of that from tobacco control. And we aren't just talking about lung cancer. In the lower left-hand panel, we can see that diseases such as hematologic malignancies, breast and GYN malignancies, GI, of course, head and neck and lung, and many others are all negatively influenced by the continued use of tobacco. And overall mortality is influenced by a 50% risk and a 60% cancer-specific mortality. So uh, getting patients to quit smoking can have a significant benefit. If we get smoking cessation, we can have a significant reduction in mortality. Obviously, we can see the cost of ongoing tobacco use, and the mortality risk is dramatic. And these panels, I think, are really important for us to understand that in many of these areas, contemporary management now with immunotherapy, combined therapy, these new treatments that are even in the Pacific regimen and some surgical patients, when we look at the advantages of the drugs that are being used. But in the lower right hand, we see the influence of smoking cessation in addition to first-line treatment for non-small cell lung cancer, and just adding smoking cessation in addition to their other treatments has as much of an impact based on the hazard ratio as these new drugs that we think are so powerful. So this is a tool that we need to leverage, and we need to find a way to bring it forward. In the work from MD Anderson, where Dr. Warren worked on this as well, but this publication came out in November of last year, just a year ago. And it shows for people that quit smoking within 6 months of their disease, we can extend life by nearly 2 years, 1.8 years, and just by adding smoking cessation to their additional treatment. And for those patients that live a bit longer, the advantage is still persistent, with a 4-year advantage for patients at the 50th percentile. So we can see significant changes in those patients. So there's reasons why we need to continue to drive this effort forward. And there have been numerous efforts to be able to help accomplish this. And you all, more than most, have worked in over 50 NCI designated cancer centers to try and develop clinical cessation programs. The NCI Scale Initiative, looking at 8 centers to fund ways to link smoking cessation to low-dose CT and lung cancer screening, Canadian initiative, and of course our work that I'll describe with the American College of Surgeons Commission on Cancer. And so, these have been going forward, but how are we actually going to make a change? And so we knew that the end game for this was going to be the ability to leverage the Commission on Cancer. We just needed background data in the COC environment to be able to learn that we can change behavior and we can lead more patients to better referral for effective tobacco treatment. And so we started with the first program that Mike mentioned, the Just Ask Quality Improvement Project. It was ran over 2022. And in that year, we were focusing just on assessing and documenting tobacco use in the electronic medical record during the time of their cancer treatment, not whether or not a primary care doctor had checked a box 3 years ago, but are we talking to patients about smoking cessation or about their tobacco use during their cancer treatment? And then in 2023, we took the work even further to look at Beyond Ask, where we said, okay, we're not just asking anymore. We now want to know, can we actually refer these patients to effective tobacco treatment? And in the course of these 2 projects, we influenced the care of nearly 1 million patients. When we had 700 cancer programs across the country that adopted participation in the Just Ask project. 650,000 cancer patients were reported on their tobacco use during their cancer treatment. And then in Beyond Ask, we were asking for a little bit more from these programs. We had 300 cancer programs participate, and about 250,000 cancer patients participate in this that were influenced by this to lead more patients to effective tobacco treatment. So this is Just Ask. We found that in the very beginning, approximately 88% of the patients that were participating in this were having documented use or absence of use of tobacco during their cancer treatment. And we improved that to 92%. So that was good. But during the course of this, we weren't even looking at assistance. We measured it, but we weren't even asking these programs to try and increase assistance. And just by focusing on assessment, we were able to see assist rates go up from 53 to 67. And so in that setting, just over the course of a year, we were making changes in the behavior of these programs. And so that's what led us to the Beyond Ask project. And in this, we were seeing consistent high rates of assessment of tobacco. What are the ask rates? And so those were good. The assist rates in the overall, in the blue dots, we were able to see that we were able to move programs overall from approximately 45% up to 68%. And with that, we were able, and that was overall. Now, some programs that we described as full adopters that embraced several implementation strategies were able to move from that 40%, 45% up to above 80% in their referral to effective tobacco treatment. We weren't able to follow these patients to see whether or not they actually sustained smoking cessation, but that wasn't the point. The point was we can't get there unless we get them to effective tobacco treatment. And so this was the next logical step. For those programs that we see that were not, that were only partial adopters, that did not take on several of the implementation strategies or fully engage their institution, we actually saw those rates fail to improve. And so I think that it was important for us to be able to deliver a package that encourages these programs to adopt implementation strategies across the board. And so this was really impactful. And then Tracy Poo, a scholar who's been working with us previously with the NCI, now is at the University of Alabama completing her surgical residency, has collated this information and has put this together for us to be able to show where our programs were actually able to make a difference. And I think this is really impactful to look at what was making the change in the first 2 months in the blue bars. And you can see that referral to the quit line. This, didn't require any new resources, didn't require any new hires, it didn't require any new strategies for these programs other than to recognize that a quit line existed in their state and that they could increase referral to that quit line. They also participated in office brief counseling, but over time, and then looking at it again in the 10 and 11 months time period of this study, you can see that things began to shift, and we were seeing the significant uptake of tobacco specialists, nearly double the use of tobacco specialists, significant increase in understanding the community resources that were present. Web-based referrals began to pop up, and brief in-office counseling was continuing, and behavioral counseling was a significant increase as well, nearly triple. And so these are behavior changes in these cancer programs that are participating just within a year. And this is under the influence of a quality improvement project to try and drive these programs to do more. So all of this data has led us to understand and to believe that we can continue to influence assessment and effective treatment for patients that are going through cancer care. And so we developed a new COC standard 5.9, that all cancers patients in COC accredited facilities will be evaluated for tobacco use within 30 days of their diagnosis. And then we will calculate the ask rate and report that every year for each of the 1,500 or so cancer programs across the country. And so a threshold for compliance to be able to meet this standard is 90% of patients, of your cancer patients, have to have documentation of tobacco use in that. And this is measured by an audit that the program's complete, and then in a triennial site review, the site reviewer will review this information and go over how this information is collected and how programs are moving forward. Additionally, all programs for those patients that are found to be positive for tobacco use have to then determine an assist rate. And this is the ability to move patients into effective tobacco treatment by establishing a referral in this pattern and into these programs. Certified tobacco treatment specialists, quitline if it's available, other resources that are present in these institutions. And I think we're going to see, just like we did in our one-year project, more programs driving to more effective tobacco treatment. And that threshold for compliance is 80% of those patients that are found to be tobacco users have to be documented to show a referral, not just a pamphlet thrown across the desk, not just a recommendation that they do that, but actually assisting these patients with a referral by making the phone call to the quit line, by making the referral to a certified tobacco treatment specialist. So 5.9 is a standard which is going to be implemented in January. And the way that this goes is that programs will have the first year, 2026, to be able to establish their process of how are they going to achieve compliance with this. They will not be penalized if they are reviewed at site reviews and by measuring what's happening in 2026. But beginning in 2027, they will be held to the expectations that I showed in the previous slide. So this is our way of phasing in this standard. And so the process requirements are defined. The program must implement a process and a policy to screen for smoking status in patients with newly diagnosed cancers. And then the referral must be receive or be referred for smoking cessation treatment consistent with evidence-based guidelines. And the services can be by delivered on site or by referral. And our expectation and frankly, our education is that we want these programs to move more into on-site care for these patients, just embedding it in their own cancer program. And the audit requirements are here for patients. They have to audit at least 20 patients and document those screened, those who reported smoking, and then those who referred or received smoking cessation treatment. And then an action plan if the program comes up short, then they've got to tell us the story as to what they're going to do differently and how they're going to change the influence of that. Here's a link. If you want to have access to the full standard 5.9 text, you can take a look at that. We welcome your evaluation of this. Your input is critical. All of the standards in the COC are living standards that we establish. We want to have consistent messages to our programs, but there are adaptations to these in our accreditation committee every year. And so we'll be looking at the performance, listening to the feedback from the programs, and ultimately being able to hone this standard into exactly what it needs. Just a brief moment about what the COC is. This is too small for you to see, but I've shared these slides, and you're welcome to these. But this is a list of the member organizations that participate in the COC. And you can see that they're professional organizations that run the gamut of all kinds of provider specialties, but also the NCI and the Department of Defense and the VA, as well as ASCO and American College of Radiology and just a whole spectrum of folks. And everybody has the opportunity to have an input into all of our standards. Commission on Cancer represents the the presence in the entire country. Um, you can see the density of sites that are represented here, and it's actually quite impactful to have more COC facilities in your state. I'm pleased to be able to state that Kentucky has the highest density of COC accredited programs per capita. And that's intentional. It's because we have been drilling into rural cancer programs to try to get more of these. And you can see that the center part of the country is not as well represented as the east and the west. But our intention is to continue to drive, and we've got a whole new set of standards for rural cancer programs to try and improve accreditation in that setting. The COC is a structure and a methodology, and I think this 5.9 really demonstrates that very clearly. We took it very seriously to follow evidence-based guidelines, to use existing information to be able to inform our standard. And we've done that in all of our standards. We drive multidisciplinary care. We provide quality metrics for comparison. And since we use a common structure for all programs, large and small, we have the ability to be able to compare programs between each other. And since we're consistent in our standards, you can see programs' performance over time, improvement or challenges that occur. This is a list of all of the standards, absent 5.9 because it's not active yet, but we work through the continuum of care for cancer patients, whether it's prevention and screening strategies, evaluation and decision-making, including support from nursing, from physician credentials, from palliative care, rehabilitation, oncology, pharmacy, et cetera, treatment strategies. And we have new surgical standards that have come up in the last 5 years to try and influence what happens in the operating room, and we're seeing behavior change there. And then finally, in surveillance, we have a strong data component through the National Cancer Database, the NCDB, and all of our programs submit their data to the NCDB for data collection. And then we have foundational elements at the bottom that involve administrative components, facility, commitment to the COC process, quality improvement, and accountability features. The NCDB is nearly 50 million cancer patients that are included in this. And so we have the ability to extract data from this to benchmark each program against others of their same size or their same type by state and many different ways. And we have a tool called the Participant User File, and this is open to all COC programs. They submit an application with their research intent, ask a question, and the data for a particular disease site can be downloaded and sent to them in a flat file that they can use and generate new concepts for research. And it's available to anybody who's participating in a COC accredited program. There have been several articles that have come out in the last couple of years that have shown the benefits linked to accreditation, such as measuring social vulnerability and receipt of guideline concordant care, in this case with colorectal cancer in COC accredited programs, showing that these patients who participated received care that was more consistent with treatment guidelines. Additionally, hospital accreditation status and showing differences in Black patients with colon cancer. And again, COC programs were able to show more consistent adherence to guideline concordant care. Our benefits are also recognized through these QI programs. This started in the pandemic when we saw a national challenge that was screening was clearly impacted by the acute phase of the pandemic. But as Dr. Sharpless identified for us, we were at risk for many patients to miss getting back into screening. And so we implemented a first QI project called Return to Screening, and we were able to show patients that participated in those strategies were able to increase their screening rates to at or above what they were screening before. Our Just Ask and Beyond Ask project came across, as I've described. Breaking barriers was looking at barriers to care and its influence in this example of radiation treatments. Lung nodes is a way to enhance nodal sampling in patients with lung cancer surgery, and a new genetic access pilot project being able to look at the use of molecular testing in our cancer patients. So there are some additional resources. Some of them you're familiar with. The C3I obviously participated in this project and many others. And through that, you all have developed your tobacco treatment roadmap, and we have disseminated this to all of the COC programs to make sure that they understand that this is a tool that they can use to be able, and they don't have to reinvent anything. It's an open book for us to deliver in our resource portal and what we call the change packet through Dr. Burris's work to be able to help increase the efforts of our programs to have effective tobacco treatment. And this is a good example of how we can do that. Additionally, the American Heart Association now has linked with the Association for Treatment of Tobacco Use and Dependence, ATUD, and has developed a certification program for effective treatment. And so this is another way to be able to move more patients into certified tobacco treatment specialist in a relatively short period of time with a standard process. And so this has been very effective. So I'll end with where we began, and that was understanding that smoking cessation really must be addressed with all steps along the cancer continuum and in all cancer patients. And so this opportunity for us to be able to understand that we can influence the development of this disease absolutely by increasing our efforts in prevention and our work with the youth and other areas in our states to be able to have specific messages that are going to resonate with our own populations. Screening, we're seeing dramatic increases in screening. And I think that there's still obviously a lot of opportunity for us to enhance this in lung cancer. But the role of tobacco at each one of these steps is critical. And influence of tobacco on effective treatment can't be overstated as what may be the easiest, cheapest, and lowest toxicity approach to be able to improve our outcomes. So I think that we do have opportunities to improve what we're doing in lung cancer and all cancers, and hopefully you'll understand that this is a strategy that you all have participated in and that you have helped us to be able to hone this, and I look forward to your comments. Thank you.
Tim, thank you. That was just great. And we have a lot of questions that have come in through the chat box. So I'm going to start with those and then open it up for others to unmute yourself and ask questions or put your hand up. So the first is from Amy Miller, and that is regarding the standard. What if a person declines referral to an evidence-based treatment?
That's a great question, Annie, and I think that this is an area that we are open to understanding that there is free will involved in all of these patients, but we would be remiss if we did not have the opt-out strategy emphasized here. This is a real opportunity for patients to normalize tobacco treatment. As I've said, we refer patients to medical oncology when we think it's the right thing for them to get systemic therapy. We refer them to radiation when we think it's the right thing for patients to get radiation. Um, and I think that we should refer patients to tobacco treatment with the same fidelity. And so we wanted this to be exactly a treatment modality that was treated no different than the others. Because of its impact, we can see patients have better outcomes when they have effective tobacco treatment, and they achieve that with those folks that are well trained. And so everybody is supposed to get the referral. Obviously, patients can make their choice and not, but the measure of the standard is the referral. And so for patients to get that referral, not just a pamphlet, not just a recommendation to make a phone call or here's a phone number, but actively assisting patients in this referral. So that's our expectation.
Great.
The patients can decline.
Great. And Lisa Sloan had a similar question, so that would address Lisa's question. The next question, and I want to let everyone know a point that Tim made, and that is the roadmap that is up on the C3I website has information, including information on opt-out, and we're adding a new section on how to effectively implement the new standard, the 5.9 standard, and that's going to be available over the next week or so on our treatment roadmap. So take advantage of that and share that with your sites that you're working with or asking you for assistance. All right, next question from Teresa. Some of our EHR EMRs only, could someone read that question? Because I'm having a hard
Sure,
time
no
having it open.
worries. I
I
can
can
step in.
go ahead.
Uh, so Teresa asks, some of our EMRs only have a place to record tobacco use status, and it doesn't indicate specifically past 30-day use. So she's wondering how others are who specifically use Epic are planning to modify the EHR or ensure that tobacco use is being assessed as at 30 days.
Well, I would encourage you to go to your site resources and ask for adaptations to Epic to be able to do this because it's only with that that these 1,400 cancer programs across the country are going to have an influence to be able to change what Epic wants to do. And but I do think that there are strategies to be and we know this is possible, and that was we didn't put this standard in place until after we ran this through Beyond Ask, and we knew that the EHRs had the capacity to be able to measure time. And so we know that this is measurable. But again, the emphasis is not to uh, allow patients to be assessed by a primary care doc 2 years ago. And so it does take intentional documentation of this.
Yeah,
Jamie?
Yeah, I just wanted to add 2 points. One is that you all will notice that one of the strengths of this effort is that this just and beyond us goes beyond self-reported survey, that the COC routinely requires uh, clinical documentation. So, those of us that are clinicians know if it's not documented, it didn't happen. And so it does. It certainly drove these programs to work with their health informatics. And Tim and Jessica and Graham and others likely remember in the beginning of Just Ask, we saw that as the biggest barrier to completing our surveys. But as the course of the year went on, the number of programs that could not provide actual data, numerical data, diminished greatly. These programs know how to work with their health informatics programs and get the job done. And I think that's really a testament to the way the COC organizes their registry and their clinicians and their QI teams.
great. This next question is really a tough one for you, Tim. How will the standards accommodate the reductions in state quit lines across the country? Many have cut back on promotion or the availability of quitline services. Do you want to address that, Tim? I could work with it too.
Well, I think we can both do this. I think that what we saw was because the quit lines were a ready source of referrals and they were easy relatively to be able to make that connection for patients. They were the what was leaned on in the very first month or two of that study. But what we also saw was that quit lines dramatic decreased significantly over the course of the year.
Yeah,
So I think that what that just to me describes that programs began to internalize this expectation, and so they began to develop their strategies for certified tobacco treatment specialists, for being able to have internal referrals. And we did see a significant increase in brief in-office counseling. We've not included brief in-office counseling as an expectation for compliance with this standard because we know that that may not have the effectiveness that we want for tobacco treatment. And that was purely a recommendation from our task group.
Yeah. So the quit line, while just to add to that, the quit line, while one of the options for providing assistance is not the only option. So that too accommodates the fact that quit lines may not be available everywhere. All right. It was the question by Brandon. I believe it was previously mentioned in a different talk that there are resources available on the COC website on how to implement measures. Are these directions and where to access them? And Mara has already put up a link for folks to access those measures. So there you go, Brandon. Um, and Lisa Sloan has the next question. I see on the protocol for identifying and treating tobacco patients who use tobacco page and inhaler is listed as an FDA medicine. Has that returned to the market? It is, to my understanding, is not yet on the market, but that is just a carryover from it being a approved medication by the PHS guideline, I believe. All right.
Let me just add one thing to that, and that's that we live in a dynamic world, and our standard is expected to be influenced by new tools, new treatments, and that sort of thing. But the compliance with the standard is following the evidence-based guidelines that are out there, the recommendations from other experts. And so, if there are new tools, if there are new strategies, better ways to implement existing tools, those are automatically adopted by the reviewer who is evaluating these COC programs. And so, that's where we are not the content provider in terms of what is the expertise in smoking cessation. We are just implying an enforcement strategy to be able to get more people to use the tools that are readily available and proven to be effective.
All right. Any other questions for Dr. Mullett?
Hi.
Tim, sorry, go ahead.
Oh, thank you. Hi, thank you so much for this talk, and thank you, Dr. Mullett, and all of you behind the scenes who have helped to implement this as a guideline of the COC to really, I think, get people to stand up and take notice. So thank you for that. My question is about electronic delivery devices of nicotine and what the COC stance is on that. We don't know a lot about these, but as you aptly pointed out, there's about a 20-year gap. Even in the tobacco use, we do know causes harms. And so what is the stance of the COC on vapes and other electronic nicotine delivery systems in regard to this regulation? Thanks.
Thank you. Great question, Darlene. And I think that that's what I was trying to get to when I was saying this is a living document. And what we really are reacting to is evidence regarding cancer risk and evidence regarding improved outcomes. So, and I think we're beginning to gather more data on these on these tobacco delivery systems. And I encourage every one of us to look for opportunities to be able to define what the risk is associated with this and what the benefits of cessation of vaping or the risk of continuing that. We really wrote our standard to be built around the evidence that was around combustible tobacco. Now, and again, would welcome the more evidence to be able to incorporate combustible tobacco in the form of those inhaled devices. But right now, our strongest evidence is in mostly cigarettes and combustible tobacco, and so that's where we really had our expectation. Um, there's risk associated with pipe smoke, of cigar smoke, and many of those, there's risk associated with marijuana use and other things, but the evidence that we had the strength for to align with this was really in combustible tobacco. But I would welcome anybody to be able to give us evidence that we can incorporate that and modify our standard.
Thank you.
Other questions, comments?
Tim, this is Graham. Thank you for a very good talk. And I know you got into this just a little bit, but one of the strengths I think that this provides is the strength of an accrediting organization. And I'm not sure everyone on the call understands the scope of what Commission on Cancer has done over the past 30 years. So I don't want to try and make it too nebulous a question, but in the context of practice change in the real world and the Commission on Cancer, do you have any comments on the methods that were used over the past 30 years as compared to traditional implementation dissemination methods that are seen in research? I hope that question makes sense. As an oncologist, I can see clearly the benefits of a structured clinical delivery organization to help disseminate in ways that are sometimes more difficult than research-related organizations. And any comments you have would be welcome.
Thanks, Graham. That's an important piece. And people have said that there are two things that change behavior in medicine. One is money, either reimbursement or penalty, and the other is accreditation. And I think that there's some truth in that, because if you look at, for example, every one of our institutions has, if not one, multiple tumor boards, multidisciplinary tumor boards, all of these were driven by the influence of the COC and the expectation of multidisciplinary care. When was the last time anybody saw a pathology report that was not delivered in a synoptic format? Nobody can remember the last time they saw a pathology report that was not synoptic in their contemporary cancer care, in their care of patients. And that's because that was a standard that we put forward to be able to say that you have to deliver your pathology reports in synoptic format. And now we've actually removed that standard because we were achieving that 98% of the time. And so another example of that is we know that if patients who are receiving colon cancer surgery have at least 12 lymph nodes retrieved from the patient, we are more accurate in their staging, and we have better outcomes, better survival from patients that undergo surgery for cancer. And so the standard was put in place to be able to have an expectation of 12 lymph nodes removed from every curative intent colon cancer operation. That standard, that same language was in place in the NCCN guidelines for 5 years, and there was no change in behavior and more patients getting more lymph nodes sampled from their colon cancer operations. We put the standard in place, and within 3 years, we began to see that, within the first year, we began to see it rise, but within 3 years, we saw programs achieve 80% compliance. And so this is the behavior change that happens because of standards. We've seen the same thing in lung cancer, where we had dismal lymph node sampling in lung cancer surgery performed by any number of different surgery training programs. And it didn't matter whether they were general surgery or thoracic surgery or cardiothoracic surgeons. But with a standard in place, we now are seeing a compliance with 3 mediastinal lymph nodes and 1 hilar lymph node from patients with curative intent lung cancer surgery. So just examples of how this is changing behavior. And again, it's dynamic and living, because at some point, 12 lymph nodes would be an expectation, and anything less than that would be poor care. And so we'll be able to get rid of that at some point. But I think we'll see the same thing with expectations of genomic testing in the right patients and driving that further because it's lagging behind. I'm very anxious to see us develop a screening standard as well to see us help drive behavior in screening programs and so that we can see more effective screening in lung cancer as well as the others. We already have a screening standard, but now that we have better data and we're working with NACER to be able to develop a method of detection field so that we can actually be able to understand where patients are, or how patients are diagnosed with their cancer, and for screen detected cancers, being able to look for effective screening and increasing that percentage. So it's a dynamic process. The COC is constantly looking for ways to improve, and we only are able to identify those with interactions from folks like you all.
Okay. Any other questions before we thank our guest?
There's a question
Yes,
from, oh, I'm sorry.
Katie. Yeah, there's a question from Kate Taylor.
Yes, thanks, Jamie. So Kate said, regarding the statement below from the standard, is there a definition of newly diagnosed cancer? In order to meet the standard, screening for smoking must be performed for patients newly diagnosed with cancer at an initial patient encounter or consultation within the accredited program for cancer treatment.
30 days from the time of diagnosis.
Great.
So I just want to jump in for a quick second and go back to the question of how do we change our tobacco use screening from what's built in, which is it could have been assessed at any time. I think it's really essential to look at your workflows, and this addresses the last question too about how do you define a new patient. Look at how patients get connected with your center and think about inserting a new question that does focus on the 30-day time frame that can go into those workflows. And that's what we're doing in our own cancer center. We're looking at some people come through intake nurses, some people work with nurse navigators, and looking at all the different entry points and trying to use the same question in all of those settings and to train everybody to do that. And it's essential to do that because the canned tobacco use status that's in the EHR is wrong a lot of the time. In a recent study, we found that 20% of people said, oh, that's way out of date. That's not accurate anymore. So it's really great that the standard specifies what is your tobacco use status at the time that you're entering into cancer care.
Thank you, Danielle. I'll just add one more thing to that, and that's that this is from the time of their diagnosis. Now, you all are working in programs that are often receiving patients in second opinions, or you get patients further down the line. And so this is technically, it doesn't necessarily apply to you. We obviously are welcome, and I hope you have a workflow that makes it so that these patients get asked this question about tobacco and get offered the opportunity for referral to effective treatment more frequently. But the expectation, this is measured on where the case is analytic, where is the case diagnosed and or first course of treatment established. And so if you're seeing patients further down the line, don't feel that you're going to be penalized because this patient was diagnosed 3 months ago or otherwise. That should have this standard will be measured at the previous site. And so hopefully they're a COC accredited program. And so I think that's part of the expectation is that this is to be community focused. We welcome opportunities for referral for research, referral for second opinions and other downstream treatment options that arise, or referral for surgery or referral to other management. But it's supposed to be associated with the patient's initial diagnosis and the location of that initial diagnosis. So that may help also.
Dr. Mullett, thank you so much. For those who asked, this presentation has been recorded and will be available after the presentation. Tim, that was great, and what a wonderful legacy of the work you and your colleagues have done to really fundamentally change the way we deal with cancer care. Thank you so much for joining us today, and bye-bye, everybody. Thanks for joining.